So it is week 3 now. As I said, it's moving very quickly. Today we're going to do chapter 22, healthcare adaptations for the child and the family. We know that there are NCLEX questions due. Make sure you do it in the proper format. If it's not, I'll just tell you it's not. I'll send you an instruction sheet and you can resubmit it, okay? I'm not going to put you down if it's not done the first week. You'll still be able to resubmit it. Make sure you do follow the instructions on what topics I want, because they're going to be following in what we're studying in class, and it makes sure that you go through all of them, okay? And then of course next week, because it's an exam, it's just the discussion question. So discussion question, actually it's due by Wednesday night, so it's actually a good one in front of doing this exam. So make sure you do it and you're understanding what it says, okay? Just a big hint, you're going to see stuff on the exam from it. So we're going to do the PowerPoint first, and then I've got a Kahoot. I use it also on the RN program, but it is perfect of all the descriptions of things that you do need for these adaptations for children. And you'll see as we get there and do that PowerPoint. It's actually a pretty good one. So let's start with the PowerPoint. Again, anybody, any questions, stop me at any time, okay? I do not mind. Now you might have this PowerPoint or another PowerPoint that's another color. They are the same PowerPoint, just to let you know, okay? So how do you get into the pediatric unit? Well, first thing we need to do is through the admission process, right? And part of that admission process is going to be signing for that. Who signs for it? Well, you need to be the guardian or parent or the legal guardian, and you need papers in order to prove that. Also, remember 18-year-old children that are alert, cognitively aware, they can sign and have to sign their own consent for admission, okay? This also means as a nurse, you must ask that 18-year-old if you can speak with the parent, because again, now it's HIPAA. It's the child who's in charge now at age 18, which I know in some families can be a lot of issues, but that's just what legality says. Always make sure there's an ID bracelet on. You know, there's been a lot of errors because people walk into rooms and they just give meds to the bed numbers and not checking, their IDs. And this is in the past, remember, I've been a nurse forever. So I've seen it where wrong medicines be given to the wrong patient because they didn't check IDs. So today we are really on top of it. I know a lot of little reviews that the managers do is go around and check each client, each child, do they have an ID bracelet? And if not, is it there on the bed next to them, those who cannot wear one, okay? Also, the parent's gonna be given one. A lot of times parents will call in when they can't be there, and there's identifying things on that we would ask for in order to give that information over the phone. So ID bracelets are important. What else do we use with ID bracelets? Well, fall risks, right? And we also do allergies would be put there also. Safety measures, whether you're adult or children, you have to remember to put up the side rails, whether it's the crib side rails or whether it's, they're in a bed, those side rails, so that they don't fall off. The other thing is some of these children do crawl, especially when you get to be about 2. They're going to try to crawl up over the rails. So there are these plastic bubble top type cribs that confines them in there. And those should be used so that they don't, because they'll fall on their heads. And then who's responsible? A hospital, because we didn't provide enough safety. And again, as I said, use your ID bracelet, never the room number or the bed number, because there will be errors. When you have a kid in a crib, the one thing we forget about is they can put their little hands out. We usually push it right into the area where the oxygen stuff is, right? Or the blood pressure cuff. Now, if they can get a hold of that stuff, well, that blood pressure cuff, they can wrap their heads in it, and those otoscopes, same sort of thing. If there's oxygen, we have, the tubing. So make sure, of course, any electrical socket. So make sure it's either pulled out or it's on another wall so that we don't let those children touch those sort of things. When we have children that are in hospital and they have toys, we have to be careful for safety. We don't know if all of a sudden a kid might have a seizure, right? They could have a febrile seizure. And there they are in the crib, in the bed, and some of these toys can have sharp edges. And there they are moving with a seizure, and they could get cut and injured. So we need to make sure that these areas are not sharp there, and those removable parts are not little so that they can swallow them, right? That they're age appropriate. Not all parents give the children the proper age appropriate toys. Medicines and solutions, keeping them out of reach. You're not just going to leave something on a bedside table for these children, have mom give it later. We're going to come back and give it later ourselves. So we wouldn't ever do those sort of things. We do not let children borrow toys from each other unless we're going to take and wipe it and disinfect it. As I said, what do toddlers do, right? In daycare, they swap spit. They go one toy to another toy, they play, right? That's what they do. But doing that actually gives them more germs. Yes, they do get sick, but what happens to their immune system? It gets better because they've had that virus or whatever it is. But if you have a child in a hospital, there's already a problem. They're already, a little bit depleted, their immune system. So make sure, yes, you can use my iPad, but let me clean it off for you first, right? Making sure that they don't get any things. Giving oxygen to children, you think it's, big deal. Remember I said there's that tubing there, and that tubing can cause a lot of problems. So we need to make sure that we're taking the best precautions so they don't just wrap up in the tubing and choke themselves. Children that are up and walking around, a lot of them like to see wheelchairs and wagons and stuff in the hallway, and they like to play with them. So they shouldn't be used like that as a toy. Children should never be left alone, especially in a swing or anything. Doesn't matter anywhere, or a high chair. They always need to be monitored, and remember to strap them in. Use the safety belts. Small children cannot be just left, let's say, on the floor or anywhere when they're not attended. Again, make sure they're in the crib, side rails up. And another thing is, it's easy just to go ahead and give a kid a bottle and prop it, and they'll just sit there and drink it, right? But remember, there are choking risks, and parents might do it at home, but us as nurses, we should never do it, or we shouldn't let parents do it when they're in the hospital. Now, how do we get the kids around, and how do you transport them? Well, kids are a little bit different, especially the littler ones. It depends on their age and how sick are they. Some kids might have to go down in a hospital bed, or might have to go down like to X-ray in a crib. So this is something to think about. The pediatric hospital I worked at for years did have little red wagons, and they put little safety straps in them. And then we would let the parents come down with them, or if parents not there, they would just take them, strap them in, and we wheel them down, and it would be more fun, right? You're going to say beep, beep, move out of the way, and these kids just giggle and laugh, and going to X-ray or doing a procedure is not a big deal because they had fun getting there. As we're transporting, make sure those side rails are up. Many times you have to put the side rails down to get out of the doorway of their rooms. Make sure they go back up. That's one thing that I see that does happen. Make sure you check the ID bracelet if they have one on before they go anywhere. Because once they get to another department, what's the first thing they do? They check the ID bracelet to make sure the patient they're doing whatever procedure on is the correct one. And another thing is to make sure that we're documenting. Is it documented where the child went, at what time they went, who took them there? Because if they're gone for an hour and a half, now you're off shift, it's documented. You sent him here with this person this time, and then the other nurse can follow up. Hey, what's taking so long? What's happening to my kid? Is he okay? Do you need me? You know, when we do assessments, we know children are different. Absolutely. There is no head to toe on a kid. You get what you can when you have that ability. For instance, you know, if children, you're doing an assessment and you have an infant, and that infant is asleep in mommy's arms, I'm going to be listening to their heart rate and their heart. I'm going to be listening to their breath sounds and their bowel sounds because they're quiet. And I'm going to be able to listen, right? You know, a lot of times we have to do get this information so that the doctor knows what you're hearing, what you're seeing, getting height and weight, and you know, sometimes it's two views that brings together a diagnosis. I know many times where I've gotten new infants into the newborn ICU after delivery, and I do my assessment and I find things that need immediate attention. I've found a cardiac one where the aorta had a kink in it and I couldn't feel pulses in the lower extremities. So I notified the doctor immediately for them to come and see if they felt that too. So, how do you do an assessment on an infant? Well, remember, infants lose heat quickly. So, you're never just going to undress them. You have to slowly take off what you want or have them in a warm, radiant warmer if you have that. But at a doctor's office, you're probably not going to have that. Sometimes the ER has them, sometimes they don't. So just only take off what you need or put your stethoscope underneath the t-shirts to listen to their breath sounds, bowel sounds, et cetera, et cetera. We know when we're doing assessments on children, there's the first thing we do is just to look. You can see if a child is sick or well appearing just by looking. You can see a kid who's quiet, who's not moving. You can see signs of pain, their color, the way they're breathing. We can see that just by looking. So that's the first thing we need to do. Then we could go ahead and slowly go and do that assessment as we can. The pacifier is well loved by an infant. How does an infant soothe themselves? Through their mouth. Everything, they explore the world through their mouth, and they are also going to self-soothe. So using a pacifier, it decreases stress and gives comfort. When you're done with this assessment and you've unwrapped this child and they're just not feeling secure, this is the little infants, the small ones. Make sure you swaddle them back up and make sure that they're, you know, rocked a little bit and that they're comforted too with the pacifier. And have mom do it. If mom's there, let them do it. And always talk quietly, calmly to the baby as you're doing stuff. And you're like, well, the baby doesn't understand. Well, the mother does, don't they? And they can see and hear what you're doing. And it makes the comfort of the parent a lot better. And of course, the child feels the parent better. They feel more comfortable too. That's what we use as that teaching opportunity. I always talk to the kid so that the parent is hearing what I'm doing, what am I looking at. So at home, they can do the same thing. So I'm teaching. And then when you're done, of course, you're going to document. So as I said, it's always well appearing, sick appearing, and it's easy. A kid who's running around, you know, laughing, giggling, it's going to be a real sick kid. But the one who's not moving and you can see him breathing hard, or you can hear the breathing, that kid is going to be the one that you're going to work on first. As you're watching that child, you're going to see, can they lift their head up as a newborn infant? Are they 4 months old and their head's not lifting up? Or are they not talking and they're 2 years old? I mean, there are things looking for that developmental level of the child. Are they where they should be? Okay. And another thing is when you're looking at a child, you can look at the interaction. And they say the environment, and I'm also saying the parents. Is the child and the parent, are they paying attention to each other? Do you see a calm environment? Or do you see a kid just in a room doing whatever they want? You know, where the parent is not as engaged as they should be. Remember that parent brought that child in, so they do care. It's just maybe a difference in culture. But again, making sure the parent is aware of what they should be doing to keep that child safe. Now, the way the kid looks is, again, I'm saying, is can tell you little telltale signs about pain. Where is it? You see a kid banging his head or hitting the ear, or you see that leg's moving, something's going on somewhere. I think that when they're moving their legs up and down, could be a lot of gas. Touching the ear could be an earache. Sometimes they shove their fingers and their whole hand down their mouth when their throat hurts. They're telling you this is what's going on. One of the things that I've seen in infants, smaller child, that all of a sudden they arch, all of a sudden they're arching back. They're refluxing. And that might be the first time somebody has said, wow, this baby's refluxing. And there's things we can do to prevent that food from going up and down the esophagus because it hurts, it's painful. As you're doing your assessment, you're going to make sure there's not any cuts and scrapes and bruises or anything on the child or the infant, because always your goal is to keep the child safe. And doing that is making sure there's no signs of abuse. Now, in my career, I have seen some horrible abuse, things that to this day makes me hurt just thinking about them. And one was just a bruise behind an ear. And when I picked this 3-month-old infant up to weigh them, my fingers squished in that area. And then I knew something was wrong. And in the end, that 3-month-old was abused. The father was home with the child, taking care of it, and he wouldn't stop crying. And he banged him against the shower tiles around and gave him a concussion. But he also had a fractured humerus, fractured ribs, and a fractured femur. So my goal, immediately when I suspected, I went in and told the charge physician and the charge nurse. And of course, all the authorities were called properly and everything was done to keep that child safe. So always remember, you've got great parents out there. Kids fall down, they get bruises, and that's normal. But just remember, your job is to keep a child safe. And another thing we could see is how clean is the kid. Now, it doesn't mean if the kid comes in full of dirt and mud that they're not clean, right? We know little boys. I know my Christian. He loves to get from head to toe, dirty food up and down everywhere, dirt everywhere. But he takes a bath every night. So you can't always go by cleanliness. So the history. When we're looking at history and let's say the kid comes in with a broken arm. Mom says fell off of in the playground and fell on the ground and he broke his wrist. And then you get the kid over an x-ray without mom around and he says he fell down the stairs. Something's wrong, right? Again, history does not tell you what the real story was. There is conflicting. That's going to tell you something's going on, all right? Now, as we're going through doing our history on these parents, again, we're always teaching them whatever we do. You're acting like you're talking to the child, but actually the parents are listening to you. Now, some of these parents, are into alternative type medicines. For instance, as I told you, my husband is Jamaican. If you get sick, he's going to make a garlic ginger tea, where he just takes the garlic and the ginger, puts it in water, boils it like crazy, strains it, and a little honey when he's done. And it helps. Some of these little colds and viruses goes away. But sometimes these can interfere with regular medicine. So we need to know about those things. If there's anything else that they're doing for their child. They came in with a cough, cold. Any home remedies you're using? Because they can make a difference. We need to know how they're eating, how they're sleeping. Are they potty trained yet? Kids 4 years old, are they potty trained yet, right? What do they do? Do they get up? Do they ride bikes? Do they go swimming? Or are they always, on the computer and the TV at home? Some of them will tell you, some won't. And then look, is the kid communicating well? No, this could be hearing problems. Yes, they're having hearing tests at birth, but what if that child had chronic infections? It could affect the hearing. So sometimes if they're not listening, they can't hear, they might make these gestures and stuff, or it might take you several times to get their attention. Pay attention to that. That might be the one clue they need to get another hearing test. So as I said, it's the head to toe is not going to be that way. It's going to do as you can do it. And all of these things we're going to be looking for. But again, it's going to be as the child lets you do it. Now, how are you going to approach any child? Especially you're talking about the older infants, toddlers, preschoolers, and the young school-age children. A lot of times they're scared of you. What have we done every visit to the doctor when they come in when they're very young? They get a shot, right? They're getting immunizations or drawing blood. And that's all they know. All we do is create pain. And does that physician's office, that pediatrician's office, do they do numbing creams so they don't feel it? Not all of them do those things. So getting on their level, gaining their trust can help. And again, if as nurses, making things as painless as possible really helps. And it could be just positioning, could be using distraction, giving them stickers, having the TV on, music, iPad when they're done, whatever. We can get a lot of this stuff done. And another thing, as we're doing like blood pressures and temperatures, have the kid touch the stuff. Have them take your temperature first. Have them do your blood pressure first. And then what leg, arm would you want to do your blood pressure? And I'm telling you, they will work with you. Taking a couple of minutes to do that little play is going to let you do a complete assessment, even on the toddlers that really don't want you around, okay? They're going to do it quicker than it would if you held them down forcefully, which is you never want to do that. Now, we do radial pulses, temporal, mandibular, femoral, we do, carotid. When do we start doing radial pulses on a young child? They say age 2. Before that, we have to do an apical because that's the only accurate way. They say that younger than 5, it's, the apical pulse is advised for it. That's if you have a cardiac condition. But they say at 2 is the youngest you can even consider doing it, okay? So it's a little bit different from what the slide says. Respiration rate and character is important. Sometimes I put my hand over their chest or behind them so that I could feel the respirations, because it goes up and down sort of. Sometimes if you're just watching that child, they're going to be embarrassed and they're going to move away and you're not going to get a good count. So sometimes that's what I do and that's how I'm going to get it. We know sometimes the heart rate is elevated. And why would it be elevated? Well, if a kid was just running around, well, that's obvious. But if they have a fever, your heart rate's going to go up. It's trying to compensate for the temperature. Or if they're dehydrated, right? That's also not enough volume of blood. So their heart rate's going to be faster to try to catch up with it. And as I said, with infants, if possible, those respirations you do first before you touch them, because they're calmer before you touch them. Now, blood pressure cuffs are all different sizes. There is a 00 for your little 500, 600 gram premature infants, which is like 1 pound babies, okay? And it's like the size of my finger, and it wraps around their little arm or their little leg. And it goes up to extra large adults. So as a nurse, you're going to have to choose what blood pressure cuff works best. Because too little, too small of a blood pressure cuff is not going to lead to an accurate blood pressure. Now, blood pressures in children are lower. When you start out as a brand new infant, a normal blood pressure is 60/40. Really low, huh? but that's normal. And as they get older, your adult 120 over 80. It's just the way the bodies work then. The heart rates are higher and then they become lower, but blood pressures start lower and become higher, okay? You can put the blood pressure cuff on the upper arm, lower leg. They all lead to an accurate blood pressure. Sometimes we take four extremity blood pressures, and that would be in a cardiac child. And it tells a lot of different information for that physician. If a kid is crying, infants are crying, they're not going to have an accurate blood pressure. So how would I do that? Put the infant in the mother's arm or up on her chest. You know, she can sit there and hold them and then put it on the leg. And guess what? You're going to get a decent blood pressure. Now, fever. Now, I have a question for you. Why do we medicate children and adults for a fever? Why? To bring the fever down, but why do we do that? Can a fever cause a problem?
Yeah, too high of a fever can.
Very rarely do you see issues for high fevers, believe it or not. I've never seen a seizure, and I've seen temperatures up over 106. We medicate for a fever because how do you feel when you have a fever? You feel horrible. And children don't move, don't drink, don't eat when they have a fever. So we give that acetaminophen or that ibuprofen after they're 6 months old. It reduces the fever, and then they're going to eat and drink and they're going to play. And then as soon as that fever goes back up, they're going to sit back down again, stop eating and stop drinking. Pretty cool thing, right? So basically, that's all about what this thing here says. Now, hyperthermia is when you're, let's say, in a car, windows up, in 100-degree weather, and the child's temperature goes up to 106. This is the time where a Tylenol, your Motrins, is not going to work. So this is the one that you have to cool off with like cool pads and stuff slowly to get it down, because you can still have this is the time that you could have a seizure when it's due to something besides a fever or an infection. So how do you measure the body temperature? There's all different ways that we do this today. Orally is a good one, but an infant, is very difficult, right? They're not going to close their mouths. So that would be your older children. Usually axillary is what we do. And at birth, usually it's rectal. We don't try to do rectal all the time because a 2-year-old, doing rectal temperatures, that kid's not going to like that. But underneath the arm, they can work with that. We've got these fancy type of thermometer stuff. You can do the tympanic temporal artery is great. And then another thing that we have is, they say the core of the rectal mucosal tearing. Yes, but it's more about the child. But there's actually, as you are in the intensive care unit, and let's say the kid has a Foley catheter in after surgery, they actually have a temperature monitoring gauge on that. And you actually can watch a continuous temperature, which is pretty cool. But that's, that fancy stuff when you have all of that equipment and monitoring things. And pain, we talk about pain a lot. We consider, excuse me, pain is the 5th vital sign. And every time you go and do a set of vitals, you should be doing some sort of pain assessment. Now, many hospitals have little programs set up. I mean, the one that I was involved with had something called PI. And it was all about pain. And P is for pain, I is for an intervention, and E, you're going to evaluate the pain. Did it work? So making sure we chart, and of course, using the proper pain scale. When they're younger, up to age 3, we'll use that flax scale, right? And that's all about faces, legs, activity, crying, and consolability. And these are used for also nonverbal children, and it works great. And then about 3 years old, up to about age 8, we're going to use faces. And kids really do choose exactly what they are. Adults exaggerate pain, children's do not. Now, their weight. The weight is all sorts of reasons why we do it. This determining progress. Well, it could say, well, they're gaining weight and height, so they're eating properly. Nutrition is good. They are growing where they should. It's also telling you the growth hormones are working correctly. The thyroid hormones are working correctly. There's a lot more that goes into why we do a height and weight at every single visit in pediatrics. Also, we want an accurate weight for the day that that child is seen by the physician. Because now if they need antibiotics or they need some antipyretics or steroids, we've got the most accurate weight so that we can administer medications the most safe. So infants, you lay them down, and I like to just take that paper that's sitting there, I'll put the heel of the foot, I'll put a line, I'll have it stretched out, and on top of the head, I'll put a line. Then I'll take out the tape measure. To try to do a tape measure next to a kid is hard because they wiggle. They're just wiggle butts. So if you do it that way, it works. The older kids, we do have that little thing where you put the thing on top of their head and the little number comes up. Just remember that thing that comes down on their head, a lot of children are afraid of it. So let that kid touch it, feel it, see it, and know it. That here, you touch it, you tell me when it touches your head. And now they're not going to be afraid of getting their height because they have to be on flat feet and backed up against it in order to get a great height. Head circumference, why do we do head circumference? Well, we do it on all infants and toddlers to see if their heads are growing properly. One of the things at birth, we have infants with heads bigger than their chest circumference. And this is one of those signs that we look at. By about 1.5 to 2 years old, the head and the chest should be equal or the chest should be larger. This is telling you that the head is doing what it's supposed to do. Now, if it's too much, too little, something's going on, right? It's too big. What is it? Hydrocephalus? Is there a brain tumor? Something's wrong. We need to evaluate that reason. And just those little measurements can tell us, oh, we need to do some intervention here. We need to figure it out. Another thing is you have a child who has had, let's say, that shunt because they've had that hydrocephalus or brain surgery they've had. So they've had something done with their head, concussion, head injury. We want to measure it to make sure that there's not increasing pressure going on there. So we take it every vital signs. Beginning of every shift, nurses will do head circumferences. And it's slightly above the eyebrows, above the ear, and it goes straight around. And that's where it is done. Now, collecting specimens, how do you do them? What is the right way? Well, number one, before you ever do anything, you always make sure the doctor's office doctor's orders is there. So that, just because the RN says you need to do a urine on whatever, it might be the other kid, not this one. So make sure you yourself always check. Remember, because you're collecting it, so you've taken responsibility. Make sure you have all the equipment you need. Now, when we're doing a specimen, a urine specimen on an infant, a lot of parents want you just to bag it so that we can get a urine, right? Now, if they're coming in for just a normal routine check, that would be fine. But if they're coming in because there's a possibility of a urinary tract infection, you need to do a catheterized specimen because there's all that cheese and all the ointments and creams. It's hard to get rid of all of that. So we clean it good, put it in, get the urine out. It's the cleanest specimen. Now we've got a culture, and now we know that that culture is not just contaminants from the area, that it is the urine, not the contaminants, and that the antibiotic we put them on will probably work the first time instead of have to go back 2 or 3 times because they continue with this urinary tract infection. And then you're going to have to be worried, did we hurt those kidneys by having that infection that long, right? So doing a catheterized specimen saves a lot of worries and issues in the end. When you get that specimen, make sure you label it. If you send an unlabeled specimen, even with the proper lab slip down to the lab, they're not going to do it. They will not. They can't validate that. And you just did a catheterized specimen on a 2-month-old infant. What do you have to do? Tell the mother you have to do it again? I wouldn't want to do that. That mother's going to be really angry with me. So always make sure that you
I got a
do.
question.
Yes.
How long will it take for that infection to affect the kidneys? Because I know how long it'll take in adults, but like, what about the
You know,
baby?
remember, kids have no immune system. They have no immune system. And if I'm talking about that young kid, which is less than a year old, it could be affecting the kidneys, in a week or two, or could be longer. I mean, and then you've got a partial taken care of infection with the antibiotic, which wasn't specific. So you've partially treated and it's not there yet. So the answer is there's no real answer to it, but we know if we continue not to treat it properly, there will be damage to those kidneys. Okay. Wish I had a better answer for you.
That's okay. That's fine. That's good.
All right. So you get the specimen, you label it, and you send it down the way that you're supposed to. Always remember specimens that you need to document them, write them in the nurse's notes. And if it's urine that comes out, of course, we're going to be needing to put that in the intake and output. We can do urine, stool. Sometimes they haven't stooled. So how are you going to get a stool specimen? A lot of times we'll just take a culture and sensitivity, just a little Q-tip and go right inside the end of the anus. And that's good enough. That's sometimes all they need. Blood, we do blood a lot of times on the young infants. It's just going to be a heel stick. We only have to do a peripheral stick, like in the arm, in the antecubital, if we're doing anything that has to do with bleeding things like your PTT, APTT, anything that has to do with blood clotting, that has to be that stick in the antecube. Cerebral spinal fluid, we do that. I mean, any infant under the age of 6 weeks coming in with a fever is going to have a spinal tap because they have no immune system. We have to make sure it's not any sort of, meningitis, right? So again, label it correctly. And these usually are walked to the lab to make sure, because getting another specimen, there's not going to be another specimen. Wounds, again, it's going to be a culture sensitivity. It could be a piece in a sterile cup, or it could be just a swab with like that Q-tip thing. It depends on what the physician wants. Body fluids, we have cups, all different things. There are sterile, unsterile. Make sure you check and get the correct one, okay? And then there's always that biohazard bag. Remember that when you're transporting, because it is body fluids. And then they say urine cannot be collected from a disposable diapers. It's going to alter a result. The only time you're going to get urine out of a diaper, for instance, in the newborn intensive care unit, they're always checking to see if there's protein or sugar in the urine. And it's a very benign test. And we take a little piece of the diaper, put it in a syringe, and we squeeze it out on just this little dipstick. That's the only time we can use the diaper to get a little bit of urine. Because again, remember, it's unsterile, it's mixed with diaper, contents and fibers. So that's the only time. Then I ask you, how do you know how much urine is in a diaper? I have a size 1 diaper. It weighs 30 grams dry. I take it off that infant, and now that diaper, after they've, urinated and stooled, whatever, and now that diaper weighs 60 grams. How much does that diaper, how much is that urine output?
30.
30, yeah.
It is. You take the wet minus the dry, and 1 gram is 1 ml of urine. Yes, very, very good. Now, adults, the elderly, and the children are very similar about drug absorption, distribution, metabolism, and excretion. And what does that mean? They don't take it in and absorb it all the way. It doesn't get where it has to go quickly enough and metabolize. And sometimes because of your kidneys that are not mature enough yet, the excretion or getting rid of that drug slows down. So a lot of drug stays in the body. It takes a longer time for it to work, and then it stays in there a longer time. So we need to give the doses further apart than normal or smaller amounts so that we don't have that child become toxic. That goes with elderly and with children, okay? Now, gastric influences. Well, you have stomach acid, right? So it can, help with the digestion. Iron needs gastric juices in order for it to absorb better. In fact, they say drink it with orange juice. There's things that we can take. Let's say we took an antacid and then we took medicine. Well, what did that antacid do? It calmed the stomach down. So those gastric juices aren't what they should be, and it will affect the way that body is starting to be broken down. Intestinal influences. Well, if I'm constipated, that drug's not going anywhere. So you get maximum absorption. So maybe you get overdosed because of that, right? Well, conversely, what if you have diarrhea? That medicine goes whoop, right out, and you don't get any or hardly any absorption. So those are ways that you can see the absorption of medicines be different. And again, this also is not just children, it's your elderly also. Let me tell you a little story about topical medications. Well, I had this little boy, he was 9, I think, came in with his dad, he had a rash from head to toe. And apparently he was on an antibiotic. So I already know this is probably an allergic reaction. Well, the father was proactive. He took Benadryl cream and rubbed this kid head to toe. And he gave him a dose of Benadryl. This kid came in looking catatonic. I mean, blank stare. It was an overdose of Benadryl because of the absorption of the medicine topically applied everywhere. So, what is the moral to the story? When you're giving topical medicines or telling parents that they need to do it, less is better than more. More doesn't make it get better quicker. More can only intoxicate that child with that medicine, okay? So that even, again, elderly and your children, same thing. And remember parenteral medicines, whether it's IM, I say P is for pinch, whether it's IM, sub-Q, IV, once it's in, you can't take it back. And parenteral medicines like IM or sub-Q, remember, when you're choosing a site to use, check a site that's healthy, that's not broken down and reddened. So there's good blood supply so that the blood supply can absorb that medicine and get it into the body and get it used as quick as it can. So that's the difference of absorption. Metabolism is, again, metabolized in the liver. We also know that some the younger children and of course your elderly also have a slower metabolism due to many different things. Children, it's because of their immaturity. So you can see your liver doesn't become mature till you're 2 to 4 years old. And what if you were an alcoholic and you were elderly? Again, that's somebody else whose metabolism in the liver would be a lot slower. Excretion, well, again, you've got an immature kidney, same sort of thing. And we know once we put the drug in and it gets, absorbed and it gets metabolized and it's all over and it's helping you with the infection or whatever it has to do, it has to come out because you're taking another dose. You're getting ready for the next dose. And if you don't empty it out, what happens? You have a dose that's still in there and one that you're putting on top. Now you're toxic. And we don't want those things to happen. So it's one of the things that we do take into account with a lot of these medicines that are really what's called nephrotoxic, right? They can kill the kidneys. Ever hear of the aminoglycosides like your vancomycin? We have to do peak and trough levels. What they're measuring is how much left in the body and how much has been excreted, and that we can safely give medications with these medications to these children because the kidneys are immature. When you're giving medicines, you have usually at the bedside a parent. Use them as your eyes. Teach them what toxic symptoms, allergic reactions are. Tell them that if you see this or that, come get me and let me check your child. If you start seeing this, you start seeing that. Because you might have 5 or 6 patients, right? And how are you going to take care of all of them? You just gave an antibiotic the first time to this child, the parents at the bedside. Of course, you're going to be there a little bit, doing a little assessment for like 5 minutes, checking on stuff. But after that, you've got something else to do. Teach those parents, those caregivers, all right? They really can help you. And then always document, antibiotic given, no allergic response is seen, or shortly after administration, saw a rash on the trunk, and of course, you're going to notify the physician for those sort of things, and if we're giving medications, I have always learned to check doses. Today, it's so much different. We've progressed so far. Even the pharmacist checks doses to make sure the milligrams or micrograms per kilogram is a safe dose. But I always do it myself, just to be sure. I don't want anything happening to my kids. And all the kids that I take care of are my kids when I'm taking care of them. And I warn the parents, this is my kid right now. I'm going to take care of it like it's mine. And you know something? I get a lot of respect for that because that makes it more personal to those parents. Now, teaching. Make sure that we are teaching them everything we possibly can. And I told you, it starts with that first look, looking at that child. You're talking to the child, but you're talking to the parent. If you're giving medications, tell them what you're giving, how much you're giving, why you're giving that much, what are the doses, how to figure those things out. And then you're going to see a lot less overdoses, a lot less problems because of that teaching that you have done. Again, giving that discharge instructions or even writing it down as you're doing those teaching can really help those parents be safer for their children. Now, oral, we know, is the preferred route. A lot of kids don't like to drink it, right? They don't like to take their medicines. It's just part of it. Today we've got a lot of different choices for your acetaminophen or your ibuprofen. Find out the flavor the kid wants, or maybe they have to have a chew tab. I know, like with Benadryl, they've got those little strips. They just melt in your mouth, and the kids think that's fun. So be creative is what I'm trying to tell you there. When you give oral and they're a younger kid, little by little, you squirt it in the side of their mouth, sort of pinch their cheek slightly, and then they will, swallow it, sometimes a little bit, and I put a pacifier, a little bit pacifier. Don't just squirt it in the back of the throat. They'll gag, they'll puke. And then you have to go get another medicine and tell a physician what happened. IV, always give it as per physician's orders. You'll be giving IV antibiotics, those little antibiotics, piggybacks. After the nurse does it first, then of course you'll be doing it. You'll be setting the pump. Make sure you set it up properly and always check that IV site. Some IVs, antibiotics, they can actually burn and hurt the vein and the skin. So be aware. Maybe that one needs to go a little slower. How do you give nose drops? Well, we've learned in pharmacology all these things, but in pediatrics, make sure they blow their nose first or you suction their nose, right? And then you put the nose drops in with their head back, and then it will work better. Ear drops up and over, out and back. Make sure you know how to open that ear canal and have them lay on that side for a little bit. And I'll always take and put a little cotton there so it doesn't dribble all over their clothes. And the parents usually are happy with that. Remember eye drops? You'll pull out, your bottom of your eye, the ointment would go in the bottom of there, put exactly what they say. And again, you clean the debris first with just warm water, dry it, and then we'll put the new drops or ointment in there. Rectal, use some lubricating, have them on their side, put their knees up, open the buttocks, put it in, and then I'll squeeze those buttocks shut, trying to hold it there. And if it's lubricated or even with water can also lubricate like a Tylenol suppository. And then subcutaneous intramuscular injections, making sure you pick the right site. As the kid is older, we can give IM injections in even the deltoid. But some medicines, you don't do that. Like, for instance, one of the steroids, Solumedrol, used for like asthma attacks, that should be more ventrogluteal, okay? It shouldn't be in the arm. It burns, it hurts. So again, knowing your medicines and where to put those things. And then again, explaining to the child and the parents why you're doing it. Parenteral, you have a peripheral IV lock, which is a running IV. We just hang it up there. Saline lock, there's always a protocol and there's always a procedure written in your manuals that you can look up, and they're all computerized today. You don't have to go looking for this big black binder book that I used to have to look for years ago. And it will tell you first, look at the site. Does it look leaking? Flush it with some normal saline. Does it leak? Does it hurt? Does it burn? And then you hook it up. And then of course you flush it when you're done. And just normal saline, it keeps those locks open. We don't have to do anything else. Central lines, many of these times, they're accessed by the RN and they'll be used. They go right inside the body. So remember, as we're giving medicines, it's right directly into their bloodstream. So know that. And then if we need to flush these things, again, have the RN come and help you. Or if there's a certification that you need to do, make sure you get that done. Now, how much and where do we give things? Well, depends on the size of the child, right? So an infant shouldn't have anything more than 1/2 of an ml. And then that's mostly in the vastus lateralis. That's all your immunizations that are going on, right? A toddler, they're bigger, their legs are more chunky. We can do 1 ml. As we get older to those school age adolescents, we can put it in their arms and their deltoid, up to 1 ml of fluid. And they say that the vastus lateralis for those infants and toddlers, if we had to give an antibiotic, it would be in the vastus lateralis, but sometimes those volumes are 1 or 2 mLs, and they can be given like that. As I said, IV medicines go straight in and it is quick and you can't take it back. So again, making sure that IV site is working, you flushed it and you know it is good, because we don't want to get that phlebitis. We don't want that redness and that pain. IV fluids today, all your computer charting, every hour, they have a place you click in the computer charting that you have checked that IV site. It's always important when you're going into a room, you check the IV site, make sure it's running at the rate you put it, because remember, kids like to play, right? Even parents and visitors like to play. So make sure it stays there and then check that site. A little infant, 30 mLs could cause a big infiltrate. So, I mean, an older person can tolerate more, but younger kids can't. So make sure that we do check those sites and we do document. And of course, anything in, you must document. So how do you give parenteral fluids or IV fluids to children? Well, the developmental level of the child. If a kid sucks his thumb, would you put an IV in that hand if at all possible? No. He needs that hand, that's his comfort measure. So this is something you need to think about. Are you gonna put it in the bend of the arm so you have to elbow that arm out and board it straight? On a young kid, they're not gonna appreciate that. You know, I've had many a young kid, I'll tell them that I'm gonna numb it, they're not gonna feel it. I actually have them find where they want me to put it. And when they pick a place, I'll say, okay, that's good because of this, or maybe there's a better choice because of that. You know, children do want to be involved, mostly of all. They want to be a part of what's happening. They feel safer that way. Another thing is keeping it safe for the kid. Like many times the nurse just wants to take and wrap and wrap and wrap and tape an IV. It's not a good thing to do. Why? You can't see the IV site, can you? They have all different things they use today. They've got these little houses that you can tape and pull up and look, that keep it secure, keep that tubing, so that they can't get to it and pull on it. And usually kids do pretty good with it. A hand IV, make sure it's on a board, taped properly. And again, being considerate if they're sucking on those fingers there. Medication alerts, medication errors. Many times you're working so quick and errors are made, and it's because we didn't do something of one of these 6 things. Remember, if you didn't document it, that's still an error because somebody could come behind you and give the same thing, right? So correct patient, drug, dose, time, route, and that you did document. They do say before you leave that room, make sure the medicine is documented before you go to the next room. Doing your BSA medications, we know that today in a hospital, they do milligrams per kilograms. It's just what they do. And the doctors today have to write on there 150 milligrams per kilogram per day, every 12 hours, give this dose every 12 hours. And then again, as I said, the pharmacist is going to check that too. So dimensional analysis, if you like that, I don't like it, but you can also look at how much you need to give. I do desire over have times quantity and give the proper amount. And in pediatrics, have somebody else check it with you if you don't know. It's better to be safe than to be sorry because kids are special and you don't want to do anything to harm them. And a medication error could do a lot of damage. So we don't want to do that. Again, we looked at the IVs and the preparation of the kid and motility, we did that. Okay, drug interactions. Well, you guys are really lucky today. It used to have to be that I'd have to look up a med before I gave it to see if it was able to be compatible with something else. Today, for instance, I worked in an ER, which meant I pulled my own drugs out of a Pyxis to give to children. If there were interactions, it would be listed right there, and you couldn't take it until you said, no, that's not there. For instance, one of the big drugs in an ER is an antibiotic. Cefotriaxone, which is Rocephin, cannot be mixed with an IV Ringer's lactate. And it will tell you there, IV is not Ringer's lactate. And you have to say, no, it is not, before you can pull it out. There's certain things that can't be mixed with other things. And it's going to be part of the label from the pharmacy. And if they are those things, many times the pharmacist will have the doctor change the order to prevent these drug interactions from happening, okay? We know some drugs causes phototoxic, they could be in the sun, causes sunburns, all different things. Like I said, that iron, we give orange juice for it to be better absorbed. Look at this, egg yolks. So orange juice and your medicine in the morning, your vitamin, right? Normal. What if you're eating eggs? You can't. You're taking that vitamin. Now, gavage feedings. Yes, infants do get gavage feedings, tube feedings. You see this a lot in the newborn intensive care. You know, these children are too small to suck, swallow, and breathe. They just can't. It's just part of who they are. And what they do is they put in a tube feeding, usually in the mouth, okay, called an OG tube, oral gastric tube. And you'll check to see if there's anything there before you put it in, any aspirates from the last feeding, and then you're slowly will give the new feeding down there. Gastrostomy tube is directly into the stomach. There's different type of gastrostomy tubes, but they all do the same thing. Again, you give it small, you give it slowly, just don't push it in there. Nurses think they can just dump the whole, 60 mLs in there. And you've gone from an empty stomach to full. So again, make sure it's warm, room temperature, and that it goes in slowly, okay? Another thing is looking at if there's any sort of, contents in the stomach before you do that feeding. And they say any brown green drainage may indicate that it has slipped down. And sometimes this could be dangerous. We need to call a physician, let them know before we do a feed. Children do get enemas, and it's usually only when they're in trouble. Now, the one thing I can tell you about children and enemas is children tend to be able to control their bowels. It's the first thing. It's the first thing we do in potty training, right? Well, sometimes they will hold it when they're in stress. I've seen kids come in 7 and 10 days, not a stool. And I'm like, there can't be. No, seriously, this child has not had a stool. So you do an x-ray and you see stool in the entire bowel. So what we'll do is just a little enema, usually a PD fleets. You have the adults fleets. There's a PD fleets. And make sure you put on a nice size bigger than normal diaper. And they will evacuate their bowels. And sometimes it's a lot. Usually it's just those enemas. We don't do tap water because it's hypotonic and it pulls out a lot of your electrolytes out of the intestinal wall. We don't want to do that. Respiration, sometimes we have to suction. We've got those little bubble things, those bubble suctions for the nose, just to clear out the airway. Remember, we don't want to over suction because it creates more irritation. There are many different types of things that can cause, you could go down to the trachea and sometimes punch a hole in it and go into the esophagus, or that fistula is there already. So you can go from the esophagus into the trachea, into the lungs. You have to be careful with suctioning that. And of course, there's always narrowing, and just to clear it enough, we're not going to over put it down and over suction. Respirations, we're always going to look at the kid. What does a kid look like? We know anything with respirations and restlessness, there's some sort of hypoxemia going on. They're probably going to be tachypnic, breathing really hard, dyspneic, really difficult breathing. You're going to see retractions. You're going to see the color turning bad. And those are things that we would get help for right away. Abdominal thrusts are done when something's in the airway. One of the things I remember with abdominal thrusts is little pieces of hot dogs. Kids love them, right? But they sometimes go down and they get stuck. So doing abdominal thrusts and back blows, right? We can get rid of it. It's just part of your CPR. Preoperative, we know that children need to be prepared. What's going to happen? You can't just think that they're just going to get that happy juice and not remember. Let them sort of know what's going on and try to keep those parents with them as much as possible. Infants are never kept NPO for more than 4 hours, and even are given breast milk up to 2 hours before, because they consider that clear liquids. We don't want their blood sugars to go down. That creates another set of problems. And then, of course, postoperatively, manage that pain, okay? Let them understand what's happening and what they can have and how to take care of themselves. And they do so much better. Any questions? A lot of different stuff, huh? All right, who wants to win a cahoots? Miss Singda, are you with me? I have somebody on here, the name Jay Taylor. Is that your name known by Fortis? What is your name so I can put it in for you?
No, it's Janice Sidbury. My son normally uses my phone, and I usually change it before I get on your call. I'm
That's
sorry.
okay. What is your name?
Janice Sidbury. I could type in the chat.
Yeah, put it in the chat for me so I can put it on. I want to make sure you get credit for attendance. I saw that when you were doing the quiz and then I forgot.
Very
Oh, you. Yes, I know you. That's not how I said your name though. But
nice. That's it.
beautiful. Thank you so much. And now you're going to get your credit. All right, let's go ahead. Let's do a cahoots. What a beautiful baby I see there. Isn't that gorgeous? I love babies. My son's having a baby. You're welcome. In June. And I'm going up by Pensacola to go play with him. I'm so excited. Nana loves babies. And then I get to see my 9-year-old and an 11-year-old grandson. They grow so big so quickly. Now you're going to see this and you're going to see week 4 and a different class, but this is exactly what you need for this week, okay? So when you get it posted to your announcement, know that this is the cahoots I was looking for, okay? Who else is coming? All right, let's get going. Pediatric variations, which is exactly what we're doing in this class this week. Early detection of hearing impairment is critical, which is of primary importance. Remember I told you about that kid you keep talking to? They're not listening.
What are you doing?
So if you cannot hear, you're going to hear this kid's going to have a problem with speech, or they're not going to be saying many words. Again, that's when we need to go get that hearing checked for that child. A multi. A toddler goes to the ER, fever, headache, a rash that's itchy with milky fluid. What is the priority? So here you have a kid that has a rash and there's like fluid in it. Now they have a fever and a headache. You know, we as nurses have to think what the probability of that is. And that sounds like chicken pox, okay? Chicken pox is contagious. So make sure, protect yourself, tell the doctor, and that kid has to be isolated. Those are your first priorities. And then you'll go in to take care of the vital signs. But you got to put them in that room, get the mask on, and tell the doctor so they're aware too. A multi. Child's playing outside, runs into a piece of wood and gets a laceration on the forearm. They need to get some stitches. How are you going to have that kid getting those stitches? Doesn't matter if we're taking a vital sign, we need to do stitches, we need to do a urine cath. There's a lot of things we have to do. So again, we're trying to make it as painless as possible. We'll put on that numbing cream. Child Life is such a great company now. There are these people that have a minimum of a bachelor degree on how to play with kids. And they can have them do what? Play with the equipment, look at the equipment, understand what's going to go on. You try not to hold these kids down with mummy restraints. If absolutely possible, that's all they're going to remember. And again, let them see all that good stuff. A parent recognizes their toddler has a speech delay compared to the older siblings. What do you think she should do about that? What do we know about speech? Again, any delay, don't just assume they're delayed. Check their hearing first, then get the early intervention in and to speech therapy. A multi. What are the signs, early indicator of impaired cognition? You have a child's not up to the place where they should be, right? What are these developmental things that you know are should alert you? So everything, they're not where they should be. So if they're not understanding, they don't have fine or gross motor skills, they can't grasp things, and they should at least do a reflex, right? Grasp. They're not talking. They should do at least one word by 1 year old. And these kids, why do they have behavior difficulties? Because they can't express what they need. So those are things you would say. Tell the doctor. A child's being treated for a fever. The reason for treating the child's fever is what? It's only for the relief of discomfort. It's not life-threatening. As I said, there is such a small chance of anything happening from a high fever. It's mostly because once that fever's down, the kid feels better and starts drinking, and eating, which is what you want them to do. Another multi. A child complains of something is in their eye causing them ear and pain. What do you do with that? Is there an eyelash in there, or is there a piece of dirt? What's in there? So the first thing you're gonna do is look, see if anything's in there. Now, if there's stuff floating around there, you take a tissue, you can get it out. Now, if something is stuck in there, you leave it alone. And then they put what they call a Fox shield. This is a hard shield. They put it on the eye, and we get them to an ophthalmologist or to the ER to be checked. And of course, you're looking to see, is that pupil reacting, to see how much damage has gone on in that eye. Separation anxiety in a child hospitalized. Which behavior indicates the stage of despair? This is your discussion question you're going to see. All about separation anxiety and those different stages. So we know that when we see the separation of despair is when all of a sudden they're crying at first. They're clinging, they're out, they want them at first. And it gets to the point of despair is they're like, okay, mom's gone, nothing I can do. And then they start sucking their thumb again. Or they all of a sudden have an accident when they're potty trained. They go and they regress. That's what that one means. As you do your discussion question, you'll think about that. A child with a history of abuse, which therapy explores emotional problems. Remember, kids don't understand that they were abused. So you have to give them something that can show you what happened. in a very non-threatening way. And isn't play the best? It's non-threatening. And what they call it is play therapy. Okay? Play therapy. They can play out what happened to them. We can find out. Another multi. When can children react to the stress and anxiety of hospitalization? The kid knows he's going to the hospital because he needs to get tests and he needs to go have surgery, and he knows before he gets there, right? Usually parents don't just break it on to them as they are getting to the hospital, but before they go there and after they go home, I still have like post-traumatic stress type thing. So again, understand the child is going through that, and as nurses, let's decrease that stress as much as possible by talking to them, telling them what's happening next. A multi. An adolescent goes to the ER for treatment without parents. How do you get consent for treatment? You know, always remember that there's always HIPAA laws that you must follow. So if they're 18 and competent, they can sign. If it's younger than that, you can have an admission clerk and another one. They can get the consent, 2 people listening there. And then if it comes in that the child needs emergent treatment, don't have time for consent, physician can say, it's fine. We'll get the consent after we stabilize. And that's the way it is done. A child is extremely fearful of hospitalization. What type of play explores this? You know, many times they're afraid of hospitalization because what are we going to do? We're going to draw blood, we're going to stick them with needles, we're going to hold them down, do these x-rays, and they're afraid, right? It's called dramatic play, okay? And diversional is when you give them other stuff so they don't think about it. We know cooperative play is 2 or more kids playing together, and there's going to be a goal, like playing a board game or using these blocks and building a house. When they're done, a house is made. Solitary play is only just playing alone. When checking an IV on an infant, you notice the tissue around the IV is swollen. What do you do first? Turn it off immediately. Turn it off. It's swollen. You know, it needs to come out. You don't need any more going in there. Good. Like blood, you see an allergic reaction going on? First thing, turn it off. Call for help. In helping a child to adapt to hospitalization experience, the best approach is what? And you're talking to toddlers and you're talking those preschool children, you know, they don't like going into another place. And the biggest reason is because they're put off their schedule. If we can, we try to maintain them on that same routine. That's number 1. Number 2 would mean to bring something in that they're familiar with. That teddy bear or those jammies or that pillow or those toys that's appropriate to go there. But number 1, try to keep them on same bath time. Try the same foods if you possibly can. And it really does help with their stress. When assessing vision on a child, the healthcare provider would use a Snellen chart at what distance? It's at 20 feet, okay? And if they're not seeing it at 20 feet, you're going to tell the physician, you know, what's going on so they can evaluate them for possible glasses, right? A multi. Nursing care of discharging a child to home. What do you need to do? Get the home safe. And so the best things can only happen at home. Perfect. Absolutely. Tell them what they need, what they should be looking for. This is what you want to happen. Always those emergency numbers, and of course, discharge instructions in a written form. And tell the kid too. What is a 3-year-old's biggest stressor of being hospitalized? And that's a hard one, right? Could be all of those. But the biggest one is the separation from the parents. Because if you separate the child from the parents, everything else is lessened. That parents, they want them at bedside. Yes, they're afraid of being mutilated. Yes, they're fear of strangers. Yes, they're fear of pain, but it's mom. They want parents with them. Multi. What is the best way to alleviate the stress and anxiety of a hospitalized child? Keep them on the same routines, right? Number one, as I said, if we can, keep those parents there and always explain everything so they understand. We try not to do any invasive procedures in the child's room. That should be their safe place, okay? Something that was changed many years ago. A nurse notes a string tied around an infant's wrist. An appropriate nursing intervention would be what? I mean, you're going to see all different sort of things as a nurse. Like, what? What do you do with that? So find out what it is. It could be something cultural, right? It could be something that will, keep them safe. You don't know, so you ask. How can a hearing impairment develop? It could be present from an illness or those chronic ear infections. Absolutely. Good job. Which urine collection method on an infant is most accurate? Remember, you got an infant and they're so susceptible to infections, there's no immune system. So we want to get a good specimen to treat it the first time because we're trying to protect those kidneys. So it is a straight cath. Remember that bag urine or midstream, you're going to have contaminants and you're not going to have an accurate one. And how are you going to do that midstream? Hold the kid up like that and dangle them and wait for the urine to hurry up and catch it? I mean, think about it. It's not really practical. You do that for a 3 or 4-year-old, but not for an infant. A multi. What is the purpose and function of the family? Now we know that pediatrics is family-centered care, right? We're not only taking care of children, we're taking care of the whole family with it, which can be difficult. A lot of nurses won't go into it because of that, but it's that safe environment, it's that emotional comfort and identity, and that's where you get your values, your attitudes, and your beliefs. The primary goal in caring for the child with cognitive impairment is to the child's not thinking, can't do what they're supposed to do. I mean, you can see this little boy probably has cerebral palsy, or you have a child with Down syndrome. There could be all reasons. Be autistic, many things. But your goal in any kid is to provide optimum development, whether they're, quote, normal or have any sort of delays or deficits. Make them be the best they can be. Many infants require oxygen. What type is best tolerated and accurate? A newborn ICUs, kids come out, they're breathing hard. They call one of the things is called transient tachypnea of the newborn, TTN. They just breathe really fast, really fast, really fast. And they need a little oxygen to help. Well, put on a nasal cannula, it tickles and they're playing with it, intubate them. Have you ever been intubated? It's not fun. A tracheostomy? Well, absolutely not. But that little clear plastic little shield, they can still have a pacifier, suck on their fingers, and they can look around, and it's actually very accurate. What is the best practice for school-age children with special needs? I mean, it could be a child with visual, hearing, could be mobility. They're in a wheelchair, but they're normal, quote, normal with special needs. And you should just put them in regular classrooms, because just because they have special needs doesn't mean that they need to be in something separate and make them feel like they are something different. They need to be into regular classrooms. A multi, collecting a heel stick specimen on an infant. As I said, we do a lot of that in infants. If you think about blood and what we need to do usually, it's usually a complete blood count or CBC and usually some sort of electrolytes. We can do that with 1.2 mLs of blood in little tiny little specimen things. Now, how to do it accurately, because you can create lifelong problems if you don't do it right. Should be on the outside of the heel, either side. You should warm it up, but use a hospital-approved heel warmer. You can burn their feet very easily. And then there's special infant lancets. They won't go too deep because you could go right into the bone, okay? So that's the way you do it. And then you hold the foot down and squeeze it gently, and you'll see it. It'll bleed enough, and you put it in those little tubes. Label it, put it in a bag, and send it to the lab. Referrals for cognitive impairment should include when you can see the kid's not speaking where they should. They're not hearing the way they should. You can see they're not moving the way they should. When should you get them help? As soon as you see it. And of course, a lot of times it's us nurses finding those delays. A child with mild intellectual disability. Remember, children become adolescents, become adults, right? And we've done all the intervention we can as a child, giving them their best outcomes they can. And our goal is to try to get them so that they can live by themselves, of course, with somebody watching over them, because a lot of people will take advantage of these people, but they need to feel like they can do those things. Mild, that means there's some delay, but it doesn't mean that they can't hold a job and they can't live in their own apartment with maybe a guardianship watching them or the parents. Down's children have frequent upper respiratory tract infections. Do you know why? It could be all those answers, right? But when you think of upper respiratory, you got to think about their noses are flat and the mucus sits there and it drips, and that causes that infection and the bacteria grows there. And that's the reason why. A multi. What would be included in the plan of care of a patient with moderate cognitive impairment? I mean, how are you going to treat them? What do they need? How can you help them? How can you help them catch up? Many of these kids catch up and are pretty close, to their maximum they could be. But yeah, that's beautiful. It's the schedule, it's that exposure, good toys, and good play activities. All of that stuff can catch them up. Good job. A multi. Why do children with Down syndrome have frequent respiratory infections? Again, what is it? Again, it's that nose, and that becomes a stuffy nose because of it. And then because they can't breathe, they mouth breathe. Very good. All feeds into each other. A multi. Autistic children demonstrate which behaviors? Autistic children, we don't usually diagnose them until about age 2. It's just the way it goes. We might see some symptoms before that, but what you're going to see is these children, they're not going to be talking the way they should. They are going to be playing by themselves. They don't play with anybody else, and they don't like looking at the eyes. And do not, when you call them, they're not going to respond. These children don't like to be touched or hugged. It's just part of what these children are. And we see those things, we can make referrals and make sure they get the proper therapies they need. A multi. Children with autism have better outcomes if what? I was working with one autistic child who's autistic Downs when I was doing clinicals. And this kid went to this daycare, a prescribed daycare. Walk in every day, take his backpack off, put it in the cubby, sit down, wait for vital signs and go to play because he's had a structured routine since he was a little kid. You have to teach him how to verbalize or for him to express themselves. And you do not let these children get away with unacceptable behaviors. Just because they're autistic doesn't mean they can do bad behaviors, okay? And therapies, it's the parents too, it's family too, that the therapists teach them how to do it. The more they get from everybody, the better they do. A multi. Fragile X is another one. It's the second most common cognitive problem in children that we see. The thing about Fragile X, it's just like Down syndrome. There's one difference. They have a problem with outbursts and they're aggressive. So these children will need medications to keep them calm. Down's children don't. They're lovable, right? Fragile X is just like, but they need medicines because of these outbursts and the aggressiveness. What causes autism? Many years ago, they thought it was the chickenpox vaccine, right? It is not that. It's genetics. We don't know. Something in the brain. No reason. We don't know. So, way children with hearing impairments communicate with others. Everything, you can have 2 children speaking different languages sitting next to each other and they communicate, and how they do it, it's through all of that. Amblyopia. In an assessment, part of it that we look at is, the child's eyesight, and things that go on with the eyes. Amblyopia is that eye that sort of what we call a lazy eye. It sort of like maybe moves goes to the outside instead of straight with the other. And the way we treat that is we make that muscle work. So we cover the good eye and make it work. And we do that several times a day. How would you help encourage a preschooler to be less apprehensive when taking their vital signs? Preschoolers just ages 3 to 6. And some of them don't want the blood pressure cuff. They don't want to be weight or height. They just don't want it. They think you're going to hurt them. Again, letting them play with it. Let them play with it, talk about it, do it on you first, all of those things, and it does work. What child may be more stressed when hospitalized? You know, when you think about this, you get a kid who goes into the hospital and repeated admissions, they probably had a bad experience. And that is the child who's going to have more problems with it and more stressed. That's why every hospitalization, we should teach these children be as painful as possible, that we give less pain to them, and it will help in the long run. So a toddler has a hard time fixing on a single point with his eyes. And those child seems to cross over. They can't, you know, eyes don't work well together. They sort of move back and forth, trying to find where they need to go. And that was called strabismus. A multi. Safety and administering medications to children include we're going to do everything but check that room number, because it's not the room number we're giving medications to, right? We're going to check the name band, and we are going to be calculating the dose. And, you know, some children can give you your name, some can't. So that's not as valid. So name band, and then of course you always check the doses. What can help the parents to make a baby swallow their medicine? You know, sometimes you put it in their mouth and they spit it out, right? How can you get them to get it down? Now, I've already told you, you're not going to squirt it in the back of their mouth because they're going to vomit. Pinching their cheeks, by that, it's not going to work. Do not put it in food or formula, because if they don't eat all the food or formula, do you know if they took it? The thing is, if you put it in their mouth, you take a deep breath and quickly in their face, the parents do it. They take a deep breath and they swallow it. It works so good. Now, before we knew about infection control and all that, I used to do it as a nurse, but now I teach the parents, and they like get scared and they swallow it. It works great. Treatment for amblyopia, that eye condition of that lazy eye. How do we take care of it? So we let that good eye be covered and make the lazy eye work for it, okay? Let that bad eye work, and it strengthens the muscle. The nurse is discussing sexuality with the parents of an adolescent with cognitive impairment. What should you remember about that? I told you cognitive development, whether they're adults or even younger, people love to take advantage of them, right? For whatever reason. So when we're talking about an adolescent, especially a young girl, you want them to have a well-defined, concrete code of sexual conduct. What is a proper touch? Because they don't know. They must be taught this. A multi. A child is asking mom about his siblings in the hospital. How can you alleviate his stress and fears? So, you know, the brother's in the hospital and he's worried about them. And a lot of hospitals don't let kids in there, right? And then with COVID, you know, nobody was allowed in there for a while. But how are you going to let this kid decrease his fear of his brother being in there without him? You know, I've done a lot of different things, but make him a card. And if he can go in, Let him know what he's going to see. What if he's in the ICU and he's intubated, right? These are things you must prepare the child for. A multi. What are some best practices when a child is in pain? So give the medicine as ordered, and don't forget, don't miss doses, because after surgery, like for instance, an appendectomy, they need it. Make sure the kid's repositioned, head of the bed's elevated. Those help. Distraction is awesome. And then if we're doing any sort of things like out of bed, ambulating to chair, or instead of spirometry, give them the medicine first so they can get up, get out of bed, do that coughing, doing that deep breathing, and then it will work better. A multi. Child can be critically ill for long periods. How do you prevent pressure ulcers? And you're thinking, children, pressure ulcers? Oh yes, they can. You have very ill children that are in the hospital, and nutritionally, are they getting everything they need? Well, maybe not. And that's when you do have these pressure ulcers and skin breakdown. So what do we want to do? Well, we want to keep them dry, whether diapers or those blue chucks, whatever. A draw sheet that will help them, so you don't have to, drag them across the sheets. Turn, position, and then use whatever to keep them over on their sides, or have their arms up between the legs, and hugging their teddy bear or blankets or pillow, whatever, anything you can use. And this turning, positioning can do a lot of help so you don't get those ulcers. Another multi. Young children can be stressed by being in a hospital. How can you decrease the stress? Keep on the same routine, have the parents there, and then some good toys. Limit the visitors. You don't want to do that. Whoever can come in as long as it's following hospital policy. And last question. What types of play allows children to express their fears of hospitalization? And that's what we call dramatic play. Remember, cooperative play is 2 to more children playing together, doing something when they have a goal to reach, whether building a house with blocks or doing a board game. Dramatic plays lets them show you what they're afraid of. Number 3. Number 2. Shabria. Number 1. DP. Number 4. M&OT. So anyway, that is your Kahoots for the day.
Do we have access to these Kahoots?
I will be sending that like I always do in the announcements. I usually right after class, I'll post the recording and I'll put the Kahoots right below it. You have all of them. And if you looked at your exam review, I have them all posted there for you. Weeks 1, 2, and 3. And I have this one I'm going to put there too, because it's a different one. Okay. Anything else?